Vice President of Clinical Services for Grey Bruce Health Services. And I've been with Grey Bruce Health Services for a little over 10 years and have been working on the Southeast Grey Markdale project for that length of time. So it's near and dear to my heart.
I'm Terry Mokriy. I'm the chair of the Southeast Grey Community Health Center. We've been at this since 2005, and finally I think the light at the tunnel is showing to be not a train coming, but an actual light at the end of the tunnel.
Allan, Madden, Executive Director of the Community Health Center, and I've been with the Health Center now for about 2 months. So this is all new to me. Enjoyed it very much.
And I'll turn it over to you folks.
Great. Well, we had certainly designed this presentation together, but I'm going to be the initial spokesperson, I think, and we're all here to answer questions and to add what I forget. We're going to start. Sorry, I was trying to get that. Here it comes. Oh, there it goes. So I'm going to start with this very first picture and just tell a little bit of story about the picture before we get going, and while Rita pulls that back up. And the picture with the trees that you see on this this first slide is actually the view you will see from the new Rural Health Center. We're very early on in our planning. It was sort of late one afternoon. We were out in the field behind Grey Gables and just walking the grounds, and they snapped a picture just late in the afternoon. And this picture has become sort of our lifeline, I think, to keep us thinking and give us a vision for the integrating the healthcare that we're thinking about here in Markdale.
Does it look like that today?
Probably not today, but I will tell you that was late fall, so it would be like in November. It could have been like today. That's right. So we have been working in Markdale for a long period of time to think about what it is from a health services point of view that the Markdale and the Southeast Grey residents need. And along that planning process, the community health center was approved. The hospital wanted to rebuild from a very old building that's very difficult to provide care in. And so both of us were kind of heading down separate tracks and said, from a real practical point of view, does that make any sense? Do we need to build two buildings in a very small rural community? If we're looking after the same patients, why don't we think about doing this together? So we started off that, and I think the real vision, though, has not only come from building and not having two buildings, but rather to have some kind of synergy of care and really thinking about how that makes a difference for the patients themselves that come into hospital or come into a community health center. So that's really been, I think, what's pushed us forward, is that how can we do something different that makes sense for patients. So when we started off here to do this work together, this is something that isn't done. Community health centers and hospitals aren't combined. There aren't others that are like this. And so what do you call it so that it has a different name or a different flavor to help us, again, think about that synergies of care? And so we've used the term Rural Health Center, and certainly the LHIN staff were helpful through those early planning periods, and you've probably seen that briefing note that's come out from the LHIN to help us consolidate our thinking around what a rural health center really is. And so it combines primary care, which is the community health center. It combines acute care, which is the hospital. And it's putting that all into one facility to build that synergy of care for patients. It's really important that it's also part of a regional framework, because no area in healthcare practices in and of itself with silos around it. And so really not only the synergies within that building and within that area, but it needs to be part of a regional framework to make sure those residents have access to, for instance, surgery in Owen Sound and trauma care in London and all of those kinds of things. So we've done a little bit of work. This is small, but I thought it was really important, even though it's small, that it be on one slide, because it truly is about being together. So the Community Health Center, and my colleagues to my left here will help me if I don't get this quite right, but I think I understand it. So certainly for a group of patients in the Southeast Grey area, they'll provide primary care, some mental health and addiction support, Certainly focusing a lot on the chronic disease management and prevention, and I think a little bit different flavor than we've had in traditional primary care, a whole piece around health promotion, disease prevention, and community development. And so I think that's a key aspect that's really cool and interesting from the community health center point of view. The priority populations in Southeast Grey area that are being targeted are seniors, children and youth, pregnant women and families, and those hard to reach clientele, and some of those are those very isolated farm families in that particular rural area. From the acute care side, certainly around the clock emergency services. It is the only emergency department between Orangeville and Owen Sound, so there's a long stretch of Highway 10 there without any other types of emergency care. A small inpatient unit. Certainly routine medical and diagnostic procedures would be done in the facility, such as colonoscopy, which is certainly the big push these days from Cancer Care Ontario. Ambulatory surgical services, diagnostic imaging, and lab. And really the catchment area for the acute care side is any residents and visitors to Southeast Grey. So the ski hills aren't very far from the Markdale Hospital, so that anybody visiting there, and as we say, the highway unfortunately provides some patients to the hospital. And then, of course, any residents anywhere in Grey Bruce that do need hospital care, and that's being part of the system of care. So sometimes it may not be a resident of Southeast Grey that's utilizing a hospital resource. It may be somebody from Chesley or other places in the, because there's a need for acute care services. So what are some of the benefits? I talked about those synergies of care, and that's really what's, I think, driving us to push this forward. It's really that I think by doing this that we can enhance the primary care in the area. It's been a real deficit in Southeast Grey for a long period of time. And because of that, the emergency department for many of the residents has served as their primary care facility, and that's not best care or for those people. So we really are looking at better utilization of the emergency department for what it is meant for, and then people getting better care in the primary care setting, which is more appropriate for them. It's a one-stop shop, and this is the one building piece for many of those elderly people with chronic disease in particular. It's helpful that they can get it within one building, and just a couple of examples around blood work, x-ray, and referral to home care services can all happen for those people within one building. The recruitment and retention of professional staff in Southeast Grey has been a difficulty that we've faced over many years, and where Allan is just advertising for the Community Health Centre now, and has a wealth of professional resumes coming in, and we're just starting to see a little wedge in having some family physicians come to the community. So this hope, this vision is what we see as being a real key piece in the recruitment and retention of professionals in the area. And of course, whenever you put two organizations together and you look for efficiencies, and certainly from the building perspective, we're already seeing, in the planning piece, we're seeing building efficiencies and infrastructure efficiencies, and I think Allan and I are very hopeful as we move forward with the planning that we can also think about how we mesh personnel and actually get efficiencies from a personnel point of view.
How many people are we talking about?
In the Community Health Centre, I'll let Allan.
Right now 20, but if we grow to 12,000 feet, then that would probably grow substantially, probably up to about 30 people, with the bulk of those being clinical people.
So we thought we'd put just a little patient story together, envisioning the future as to what some of those synergies of care might look like as we build this planning function. And so this is Sally, who has a chronic heart condition. She's recently had an acute episode, and she's visited the emergency department. Her family physician has admitted her to the hospital for 3 days to stabilize her condition and change her medication so that she can go back home. She's discharged again to one of those isolated farm homes, and she's got CCAC services in the home. And that before she leaves the hospital, she's actually got an appointment. There's some good research to say if you should get followed up in, within 5 days. So certainly she would have the access to the community health center for ongoing physical strengthening and health education on her nutrition and the new medications. And then the community health center would continue to set up those routine appointments to monitor her progress, and then she can also get any of her lab work and or her diagnostic imaging that she would need right next door within the same building. And so that's kind of encapsulated in one patient, kind of the vision we have for care to be integrated fully for those for the residents. And I actually maybe get you to open your handouts and go to the bigger picture that looks like this, and only because it's very difficult to see.
Good advice.
Yeah. For those of you who know the area, on the right-hand side, you see that column that goes up and down on the right-hand side, or on your handout, it's this one right here. That's Highway 10. And then this, I'm going to just point here with my finger. It's not the best thing. This is Grey Gables, the existing long-term care facility. And so the current entrance to the front door is here, this circle to the current long-term care facility. This is the main entrance to all the basement of that building, which houses the municipality. It houses daycare and a seniors daycare. And so this is all there currently. This road would just continue, and the yellow box would be the new rural health center. And as I said, it would look out over that beautiful treed area in the back of that property. So that's the current site plan of where the rural health center would be.
Is the parking lot there now?
These
Nothing's
two
there.
parking lots are there. This would be new. Yeah, these are for, these parking lots are used for all those basement activities in the current long-term care facility. This long-term care facility is operated by the County of Grey Gables, and the property, we're working with the County of Grey in the planning process around this site plan. And this, again, is the next page in here. And this is really the piece about placing the community health center activity and the hospital activity and then meshing them together within the building. And so this arrow at the very front here is the main entrance would be the main entrance. And so you would see that this big block to the right, it'd be the space in which the community health center activity would take place. And straight ahead, you'll find the lab and diagnostic imaging, and then the emergency department and that small inpatient unit off to the left. And so that's about putting everybody together on one floor and building those synergies of care for patients together. So I'm going to stop there and open it up to questions. Maybe Terry or Allan or Maureen, if there's anything that you want to add before we open it up.
The only thing I want to add is that this project has amazing support throughout the community and throughout the municipality and at the municipal level. And it's a project in which all of the participants and the partners in the project are as eager, each is as eager as the other to get this off the ground and get this going. So what we keep doing is we keep trying to push whoever we can to see if we can get this project moving a bit faster than it's moving at this time.
Maybe just to add, as Terry has said, this has been a long journey. Sue first joined our organization as the site director in Markdale and developed a passion for the redevelopment of Markdale right away, and has moved into this more senior role, but never let this project go. And we began functional programming for this project back in 2001 and received a planning and design grant formally from the ministry in 2006. So we've been working very hard since then, and more recently in close partnership with the CHC to put together the concept of the Rural Health Center. And Sue alluded to it earlier, but I'd like to extend my thanks to Mike for the vision that he had to put together the concept of the Rural Health Center and to bring us together to do this work in this one building and in very close proximity to the long-term care center. We really do see this as one-stop shopping for patients and a very good blend of hospital functions as well as primary care services in the region. So I can't underscore more Terry's comments about community support for this project. We'll be chatting with the municipalities later this evening, and Mike is going to be there as well, just to help them to better understand where we are in this planning process. But we do have some very urgent needs in Markdale with respect to the physical plant. Some sections of the physical plant are over 50 years old, and unfortunately of our 6 hospitals, this is one that we inherited that was not properly or well maintained over the years. A very frugal community, and they did the minimal amount that they needed to do, but that decision has now resulted in some very serious infrastructure problems for us with the building. So when you have to close or virtually close a hospital to replace an electrical switch, you know that you've got a building that is really beyond its expected lifespan. So we have some urgency with respect to that, in addition to being excited to be in partnership with the CHC. So thank you for having us today.
Sue, how does the current primary caregivers in the area fit into this plan?
Certainly the current primary care providers, for instance, some of the nurse practitioners I think are interested in working within this model directly. The physicians who currently work in the area, many of them have decided to continue with their current methodology and how they get funded by the ministry, and so the office in Flesherton and the office in Markdale may continue as that, or they are also talking about building something maybe together, but there are 2 current offices. They do staff the emergency department and the inpatient unit and would continue to do so, along with any of the professional staff in the community health center.
I could just add, the CHC model also speaks to the rostering of patients, and it's also proactive healthcare. So indeed, one of our objectives is to go out into the community and find those individuals that currently don't have a primary health care practitioner or doctor, and provide support to them and services to them as well. So it's a rostering and it's proactive as opposed to setting up a doctor's office and having patients come in. The other unique thing about the model is that the doctors are employees. They're not small business people, as the current model suggests.
So, you know, down the road there is a possibility of a joint primary caregiver clinic being considered as well as CHC.
Yes.
And might happen, if possible, to locate in the same area.
Might, yes. Yeah, certainly the community is having discussions as to how that would be best managed. Yeah.
Good.
So, just to follow up on Ron's, the physicians, their input as to what kind of model would exist there and their relationship. Some of the other CHCs are struggling sometimes with those relationships with the primary caregivers, physicians. Have they given some input, and can you tell me a little bit about what that might look like, what options are being touted right now?
I think certainly all the way through the planning process, the current physicians who are in Markdale, and there's not very many of them, so there's certainly the one physician who practices out of Markdale, and the Markdale Clinic, and the 2 physicians out of Flesherton, so we're not talking huge numbers. Those 3 physicians have been heavily involved all the way along in the model itself and the planning for the functional pieces. What they've chosen to do is not to be part of the actual community health center itself. So they would continue to support the emergency department, they would continue to support the inpatient department, and those patients who are not rostered to the CHC, they would also support those patients in the community.
The dynamics in Markdale are a little bit interesting because the approval for the community health center came in 2005, not at the request of the community. It was part of a broader announcement that the province made at the time. There were some CHCs going into the GPA area, and there was an announcement made for several CHCs to begin planning. One was in Timmins, I believe one was in Woodstock, here in Markdale. So it took a little while for the community to understand what the approval for a CHC meant, because they hadn't requested one. And maybe in a different world, a family health team would have been a model that would have worked in the Markdale community as well. But I think as time's gone on, that time difference between 2005 and 11, the functions of the CHC and family health teams have more alignment than they had before. And I think primary care physicians have historically looked at CHCs in, that's an interesting model, not one I maybe want to participate in. But as family health teams are moving more to a model where, as Terry's suggesting, the relationship is almost an employment model versus a fee-for-service model, there are way more parallels than there were before. So I think as we get the services on the ground, I was excited to hear from Allan this morning what tremendous response he's had to his advertisements for human resources to staff the CHC. I think we're going to see way more alignment between what's happening with the CHC and what's going on in those primary care practices. I don't think the Markdale community, you never know, but I don't think the Markdale community would get an approval for a family health team given that the CHC is in place and given the size of the community. But there has been some discussion between a possible partnership with the Shelburne Family Health Team, even the Owen Sound Family Health Team as we go forward. So I think primary care will continue to evolve, but also they'll get a better understanding of the tremendous allied health resources that the CHC brings to the table that are just simply not available in Markdale right now. So Allan is speaking about additions to the nurse practitioners who are already in place, dietitians, additional nursing staff. So I think it can only improve, particularly for those patients who are orphaned in the Southeast Grey area, and there are large numbers of them.
I'm pleased to hear that, because the model that is in existence at some of the other CHCs they're struggling a little bit with the physician model that they have now, and the ability to create something a little different, which I think, given the flexibility that I see in this model, might create something a lot better, and it would be nice to have something that's working for both the employees and the community better than what we've seen in the past. My second question was on, were you not considering an urgent care center as opposed to an emerge when you did this conversion? That wasn't in your... Okay. I thought there was some consideration way back when for this one.
No, it's always been an emerge.
It's always been the emerge. Okay, thanks.
And just maybe to pick up on your primary question, primary care question, I just take us back. One of the other synergies that we're really excited about is that we're right close to the long-term care facility. We can offer close diagnostics and those kinds of things for the people who live in Grey Gables. And from a primary care point of view, it is the same physicians who care for those patients or those residents in long-term care. So again, in the planning process, I think there's some value in having it placed with the long-term care facility.
Yeah, the idea of this hub, because we've heard a number of times the consideration around moving fragile seniors
Absolutely.
For long distances creates quite a problem in itself. So I like this hub idea. I think there's a lot of potential here to do good for people.
Absolutely.
I think it aligns nicely with the new rural and northern document that is out for consultation now from the Minister's office. So I think that's helpful. You might be wondering why in heaven's name we didn't actually try and link the buildings. And I should share with you that we had a great deal of discussion about the possibility of linking engaged Grey Gables in that process. The cost of a link was going to be about $1 million. And we thought that was a lot for a covered kind of walkway or a tunnel. But there are some interesting topographical issues on the site. That was going to create some problems, and the sanitary sewer is running in between Grey Gables and the building, so that was going to create some problem. In the end, I think Grey Gables, from an infection control perspective, felt it might just be better to be separate, but we're close enough that you can run very quickly between the two organizations. Maybe with an extra coat in the winter time.
Congratulations so far, just so I can say that.
Thank you.
Thank you very much.
Yes.
You've got two different organizations in the same building. Is there one supervisor, or what's your governance structure look like?
Do you want to start, Allan?
Well, why don't, I think the comment that we made to Mike earlier is it's to be determined. And what I would suggest is that both Sue and I are committed to focusing on creating something that is patient-centric. And whatever spins out of that in terms of models, we're open to saying maybe the model of CHC that we currently have could be adjusted somewhat so that it better suits working a little bit more closely with an acute care facility. So we're open to change. We're open to challenging current status quo, provided that it remains patient-centric. So
Do you foresee having one board of governors for the building?
No. I don't at this present time, because legislation states that CHC must have its own board of directors and governance that way. I can see, but at the same time, we've worked cooperatively over the past X number of years and did not foresee any changes that way. Structurally, we'll have our two structures, but on a practical day-to-day working basis, we anticipate and we are working toward really close links.
One would assume you'd have one heating bill, one electrical bill, one water bill, that kind of stuff.
So from a planning purpose, where we're heading with that is that the hospital will build the building and CHC will lease the space as a starting point to have some clarity in how we manage that water bill and the hydro bill when it comes in the door. So that's where we're starting from a planning, not to say that that won't change, but.
And Ron, it is a small community, so the board governance structure for the CHC has our senior administrative staff person for our Markdale Hospital sitting as a member of the board. So that's a very helpful alliance, and Rivers Health Services has had a pretty long tradition of having cross-board appointments with our major health providers, and I can see the possibility for a potential cross-board appointment in addition to our program director from Markdale currently being on the CHC board, and I think that's been very helpful, as well as some of the board members are also board members of the Hospital Foundation and are also members of the Community Advisory Committee, because aren't that many folks who are interested in those leadership roles. So I think there's lots of good dialogue and lots of partnership at the governance level already, and potential for more.
Yes.
I'm a little confused by a couple of statements that you made. On one account, you said that the hospital was past its best due date because the community was, I think the word was used, frugal. And yet when this initiative came in, the community opened up. So there's a sort of inconsistency, and maybe I need some explanation of why on one hand for a number of years they've been frugal and now they put their hands in their pockets quite generously.
It's an easy question, and an easy answer to the easy question. Originally, the committee raised $13 million towards the hospital. CHC came around, the government said, here's X number of dollars, put a CHC up. The community said, you're giving us the money, we're doing it.
I think
So it's opportunism.
And I think there's a practicality.
And honestly, it would be opportunism. We would have been silly to have turned down the offer to put a CHC in our community, in a community which has been designated, as Maureen said, as rural and remote. And I mean, we have more problems in Grey, as people in Grey know, than pretty well anywhere else in southern Ontario. I mean, Buzzard's Crotch, Alberta's got the same problems we have, and that's way the heck up north, God knows where. And the CHC is going to answer the problem, or help to answer the problem of how do we get to these people who are farm families, who are remote families, where the level of education, the level of confidence in the medical professions in the system is basically down to simply visiting the ER whenever you've got a cold or something. So we need to get past that. One of the big things the CHC is going to be doing in this integrated unit is a lot of the outreach and the proactive education in schools and with families and with community groups.
Can I follow on with
I'm just wondering if I could clarify too, because I jumped in with that comment. I think as you're sitting here in our Meaford Hospital, this is a physical plant that historically was very well maintained by the board of directors and the administrative staff who were part of that organization prior to Rivers Health Services being formed in 1998. If you go to the Markdale Hospital, I don't know if you've had an opportunity to visit, I think that prior to 1998, the building had a CEO who was a Scotsman, and he was very frugal with his resources, and I think the building from an infrastructure perspective just wasn't particularly well maintained. So what we're trying to do since 1998 and moving forward is to do what we need to do to keep the building safe and operational, but not much more, because we're working towards obviously the goal of getting a new facility. So that's what I meant when I meant frugal from that perspective, and certainly we're taking into consideration all the patient safety potential risks there might be of an elderly building.
But in your answer, you raised to me another element question.
Okay.
That I look at the data and I see, again confirming your comment, that there's a lot of overuse of emergency for services that are really not emergency. And to me, there's a couple of issues that concerns me. One, you've addressed with the education of the community. But there's another piece that it affects physician incomes. Let's not kid ourselves. An emergency visit pays the physician on a fee-for-service more than a regular visit to their facility. And so therefore, I need some understanding of the alignment.
The emergency department in Markdale is actually on an alternate funding arrangement. Those physicians are in an alternate funding relationship with the ministry. And so they're, if you think of it, they get paid by an hour, not by visit.
Okay.
So that's been in place now for a number of years. And many of the small rural hospitals across Ontario went that route because physicians weren't able to make enough money or have enough visits to actually work in the department.
That
so
wasn't in the planning documents that
oh,
I read,
sorry,
right?
yeah, no, it's definitely
My
an
apologies.
alternate funding arrangement for those physicians.
And it's a very small group of physicians who are keeping that emergency open 24 hours a day. We have 2.5 physicians just recently in the last 4 or 5 months recruited 2 additional physicians, but 2.5 physicians, plus a little bit of help from Health Force Ontario, have been managing 18,000 emergency visits annually. And given some of the challenges this organization has had with one of our other hospitals, where there are many more physicians in the community, I have to extend my heartfelt appreciation for their commitment to keeping that emergency department open. And they do see in addition to a very dispersed geographic local population, they also see a large number of seasonal visitors, and as Sue alluded to, a fair bit of highway MVA issues, because Markdale is the only hospital between Owen Sound and Orangeville. And it's a nasty bit of highway, and unfortunately it results in a fair bit of trauma coming in. So we get ski-related trauma and we get MVA-related trauma in addition to what brings the average population to the emergency department.
And ministerial trauma too. Deb Matthews visited after skiing at Taliesin.
That's right,
Having an
that's right.
accident, so she was there.
Taliesin?
Yeah.
Oh, you possibly hurt yourself at Taliesin.
Jen, yes.
I like the concept of what you're doing. I think it's a great concept, so that part I'm really supportive about. And I'm curious about the fact that you're building with the notion that there's a growing population, and that's mentioned in a couple of places. And yet, almost every other rural population is shrinking. And certainly Grey Bruce generally is shrinking in terms of the rural areas. So why is this area growing that you need to continue to have as many beds as you need in your hospital?
I can start and then get my colleagues. It is one of the only areas of Grey County that is growing. A couple of reasons for that. One, in the southern portion of Grey County, people we feed the Honda plant in Alliston with workers, and the northern part of GTA. Many people are moving into that area actually and commute out of the area for work. The other piece is, of course, Collingwood is growing like crazy, and it's right on our borders. And so Markdale fits in the catchment area as those populations grow out into the rural area. And I think it was the last census, that particular area is growing at 6%, whereas other areas of Grey Bruce are much lower than that. So it is a different piece from a population growth.
And it does have some industry that that centers that would be 10 times as large
True.
would give their eye teeth to have.
I.e.
namely-
Chapman's. Yeah.
Namely Chapman's ice cream.
Yeah.
Big facility.
Yeah.
Yeah, and
And expanding.
and large, a large water bottling facility as well that employs a lot of people in the area.
which we won't get into.
No, because it's right beside Terry. Yeah.
The other thing is, it's the R&R factor, it's the retiring and recreational factor. It's a huge area and a huge draw for people from the GTA on weekends, as you know, everywhere from Talisman to Blue Mountains and in between. And there are huge numbers of people coming up to our area to retire and to buy places. So we've got a big urban influx of retirees coming in. And part of that is because when Interwest moved into Collingwood and Blue Mountain, the prices of land and homes and stuff went through the ceiling, so people are moving up the mountain and up into our areas now.
Okay, well, I saw the figures saying 6% versus the 3% normal, but it's still an isolated rural area as you described it. So it needed some explanation, yes, particularly if you're trying to maintain as many beds in the hospital as you are.
The actual proposal is less beds than we currently operate though, Janet?
Janet, you may not, because of where you live, have the opportunity or need to drive down Highway 10 to Toronto, going through the communities of Dundalk and Shelburne, but I've actually been quite astonished over the last 5 years at the residential development going on in Shelburne, and I don't always go all the way into Dundalk, but in Dundalk as well. And those folks look to the Markdale Hospital in large numbers for their services, so that explains the projected growth. You're quite right, in the other areas of Granby's population either staying the same or slightly tapering off.
Okay.
It's a GTA phenomenon largely.
Well, thank you for an excellent presentation. Obviously, you've done a lot of work, and you've got a long way to go still, but it's I think you have the general feeling on this table that you've got a lot of support, and it's moving in the right direction.
Keep going. Keep going.
Yeah, keep going. So thanks again for taking the time to come to this. I really do appreciate it.